Good evening, everyone, and thank you all so much for joining us this evening. We're super excited to have you here with us tonight for our panel presentation centered around unconscious bias and the effect that it can have on the treatment of Black patients. So I am Dr. Yvonne Mobley, and I will be moderating tonight's discussion. One thing I would like to note as a housekeeping effort is that although all of you have been muted, you do still have the opportunity to interact in regards to the panel tonight. So the chat function is what you will utilize. Any of the chat messages that you send can only be viewed by myself, so it'll be anonymous. But please, please, please feel free to send any questions that you have for our panelists into me via chat, and I will attempt to do my best to work those into the conversation. Now, our goal tonight is to learn about what unconscious bias is, how we may be negatively impacting our patients without knowing it, and to come away with some strategies to manage it so that we can be better healthcare providers. We are extremely grateful to have an esteemed group of panelists. Please allow me the opportunity to introduce them. So we have Dr. Angela Shannon. She is Distinguished Fellow of the American Psychiatric Association. She's the director and founder of Positive Balance Wellness Center, staff psychiatrist at Palmetto Health Council, Your Town Health, and locum psychiatrist for Georgia Regional Hospital. Dr. Shannon is from Atlanta. We also have Dr. Berkeley. She's the author of Mind Matters, a research guide to psychiatry for Black communities, and she is also a psychiatrist in Atlanta. So we are all biased, and according to experts, our biases are either conscious or unconscious. However, all bias is really discrimination. Unconscious bias can lead to negative health outcomes, and that is why we're going to focus on this tonight in regards to the biases that may be perceived towards the Black community. We will discuss those biases that happen particularly in the doctor's office, and more specifically in the psychiatric offices, or where conversations about mental health are taking place. So every African American typically has a story about their experiences with unconscious bias. I'm going to share my nephew's story. So at about the age of 14, my nephew began experiencing some mental health issues that caused us to take him in to see a clinician. However, as he was going through and describing what he was experiencing to the clinician really began to kind of ask about whether or not he had been utilizing any type of illegal drugs. Now, my nephew was very adamant about the fact that he had not been utilizing any type of drugs and that there was no drugs in his system. However, the clinician just continued to really focus on the fact that she felt like the symptoms and the signs that he was experiencing were due to drug use. It got to the point where I actually even suggested, well, if that's what you really believe that is behind this and causing this, then let's go on ahead and have him drug tested. However, the clinician commented back to me and stated, you know, every time I've done this, the test always comes back positive. I'm just pretty certain that it's truly due to drug use. Now, me being the person I am, I was unsatisfied with that answer, so I immediately left and took my nephew over to LabCorp and had him drug tested. We waited a few days and the drug test came back negative. He did not have any drugs in his system. Now, the unfortunate part about this is that later, my nephew was diagnosed as schizophrenic bipolar. And this experience, in terms of him being in that psychiatrist's office and that individual kind of continuing to kind of state that he had to have these symptoms due to drugs, has continued to really cause him to be a bit wary of going in and seeking the mental health treatment that he needs because of this initial experience that he had in regards to his care. Now, no, it's no way for me to truly determine, you know, what may have been because the reason why that individual was so stuck on it having to be drug use. But as we all know, especially with this being a young Black male, that there still was some of that kind of perhaps underneath, but that individual may have consciously or unconsciously may have been associating some of the things and statistics that we may know about young Black males in regards to kind of suggesting that perhaps this was due to drug use. Now, I want to pass this over to Dr. Shannon. Dr. Shannon, what has been some of your experiences in regards to unconscious bias? You are unmute, Dr. Shannon. There you go.
I'm unmuted. I'd rather tell the story of a colleague that had to undergo an emergency C-section and afterwards was experiencing a lot of pain. And I'm not naming the colleague, but it was such a compelling story. And, you know, basically she kept getting the rhetoric of basically suck it up and, you know, be a big girl. But because of her medical knowledge, her concern was that she might be having a pulmonary embolus or something to that effect. And that was contributing to her anxiety and pain. And only when she, you know, made it clear that she was a physician was she administered pain medications. And that happens a whole lot. And then I have other instances where patients are actually given too much of antipsychotics because of the color of their skin. So that's a couple of examples.
Definitely. Thank you for sharing those examples, just to kind of help us frame, you know, some of the different situations where you've seen unconscious bias being exhibited. Dr. Williamson, can you share any experiences that you may have in regards to unconscious bias?
Yes. I have an example that's of unconscious bias where actually I was the provider and the unconscious bias was present in the family that I was treating. And this, I cite this example pretty often, but essentially this was a nice family, and the practice setting that I'm speaking of is in kind of the suburban areas of Chicago. And so we have a pretty diverse population, but this happened to be a Caucasian family. And you know, when they came in to meet me initially, they seemed somewhat hesitant and a little anxious, and that's not uncommon when folks present their children for care. It's a big decision. But what became clear over time is that as we talked more and got through the session, they got a lot more comfortable. We got a good understanding of what was going on. We agreed upon a treatment plan, and at the end of the session, the family was very comfortable, and they were complimenting me. Essentially, they were telling me that they thought that I spoke so well and I was articulate and I really understood the information, and they shared that they weren't, because they had gone to the website and viewed my bio and my picture, and they really, you know, felt like they weren't sure how it would go, and they had cited examples in the past where they had psychiatrists that didn't speak English well and other kind of things, and they really seemed surprised that someone with 20 years of experience, which they knew by my bio, would have a command of the information and be able to relate to them and communicate that. And so what was interesting to me about all of that is that they really were well-meaning and meaning to compliment me. But what I also was able to tell was that in the information that they had about me, it led them to be hesitant or questioning of my ability. They were uncertain that I would be able to take good care of them. And again, with a bio that explains all the history and experience and then a picture, I think it becomes pretty clear that one, they were willing to come anyway, which there's that. And they were just really, really amazed that, you know, I would be expert and be able to speak clearly and help them understand things and that. And so that's kind of an example where unintentionally, even in a way in which people are trying to be complimentary and express their gratitude, the unconscious bias was still pretty evident to me.
Yes, thank you so much for sharing that as well in terms of your experiences, Dr. Williamson. And my apologies to the audience, but Dr. Williamson is a published author and speaker, as well as a child and adolescent psychiatrist at Spectrum Behavioral Health in New Lenox, Illinois. So thank you for joining us tonight as well. Now, Dr. Berkeley, do you have some experiences in regards to unconscious bias that you can share?
Certainly. First, I just would like to mention that I'm actually the co-author, one of the co-authors of Mind Matters. There are 10 of us. So I don't want to accept all the credit for the publication. So I just want to correct that. But yeah, I think that I mean, I definitely have some examples of where that has happened to me in the medical setting, but I think it's also important for individuals to recognize that these things are happening even in everyday community, in everyday, occurrences. And so what I would like to give you an example of is I'm sure that there are many people who would have experienced something like this. You go to a counter and there's perhaps a front desk staff that you are interacting with. Someone comes up, usually a Caucasian male, and they just start asking the attendant, the front desk staff, their question. You are still in front of the front desk staff and interacting with them, and they're still responding to whatever y'all are discussing. And they just come up and, they may say something like, hey, is, John Smith here, or something like that. But they interrupt your discussion as though their discussion is more important, or their time is more important, and so these situations are happening within the medical practice as well, but people are also experiencing things like this just in everyday life.
Thank you for sharing. Now, Dr. Berkeley, I also know that you personally do not like terms such as unconscious or implicit bias. So why is that? Could you share that with the audience as well?
Yeah, definitely. So, I discourage the use of the terms implicit bias and unconscious bias, and there are a number of reasons for that. And the truth is that can be a whole lecture in and of itself, but I won't make it that. I'm going to condense it. But so the first reason is that the way that people use implicit bias and unconscious bias, these are actual terms that represent experiences, but the way that they are used currently is as though they are synonymous with racism. So racism, just to give some brief example of the difference that is between these terms. So racism is the conscious belief that one's race is superior to others. It is a conscious belief. Implicit bias is basically the automatic reaction that you have to something or someone. So it is the split-second thought that you have when something occurs or when you see someone. It is like a reflex. Most of us are not operating on our implicit bias. What we are operating on are our explicit biases. So that is one distinction I want to make, and then also unconscious bias. These are things that we're not even aware that we have, biases that we're not even aware that we have. But when it comes to things like race or sex or age, we have, as adults, have had enough experience with these various issues that, for the most part, we are aware of what our bias is in these realms. So that's one reason that I discourage its use, because it's used as though to replace the word racism. The other reason that I discourage its use is I think of terms like implicit bias and unconscious bias like I think of idiopathic in the medical term. So when we say idiopathic, I know there are just a few non-medical folks out on the call. When we say idiopathic, it means that there's a condition that is occurring and we don't know the cause. So we reserve that term idiopathic for conditions where we have done all the workup, we have excluded every possibility, and now we have no other possibility, and therefore it is idiopathic. We cannot find the cause. So if it's a fever that's idiopathic, we're going to check the CDC, we're going to check urine analysis, chest x-ray, whatever. After we exhaust all of that, then it's idiopathic. And so I think that terms like implicit bias and unconscious bias should not be used until we know that it is not explicit. I don't think that we should just term something implicit bias or unconscious bias when a certain act occurs, unless we know it is implicit and it's not explicit. And then the third reason that I discourage its use is because there are not any other biases where, now you can have an implicit bias and an unconscious bias about any of a number of things. People do not tend to use implicit bias or unconscious bias in any other setting. They don't use it when we're discussing sexism or when we're discussing ageism. It is only as relates to racial acts that people tend to use implicit bias or unconscious bias. So if, for example, a female happens to be the victim of a sexist act towards a male, from a male, I don't think that male can get away with saying, oh, I'm sorry, that was just my implicit bias. No, I think he will be eaten alive if he attempts to do that. So I think that those terms are not being used correctly. I think that if we see racial acts, we should not term them implicit bias or unconscious bias. We should call them racial acts or racism. And until we know otherwise, that's how we should term it.
I'm going to beg to differ just a little bit, I spoke at the last panel about a situation where I'm pretty sure that the individual who was exercising, and I'm going to use the word that you don't like, unconscious bias, is not a racist. I don't think that they're one and the same. And it was not until I brought it to the individual's attention, what I mentioned before about heavy-handed use of antipsychotic medication based on the not just the race, but a combination of the race, the sex, and the size. So a big black man,
right?
They were on a depot in medication, a massive dose of a typical, where we don't even tend to, and that's for non-medical folk in the audience, typical just means the old-timey antipsychotic medications, Haldol, Prolixin, things like that, where we don't tend to use them on a 3 times a day basis, and seldom do you see patients on 20 milligrams 3 times a day oral, while also being on a depot, meaning a shot, 1 month injection, and a massive dose of an atypical antipsychotic. That's before you even get to the other medications. It wasn't until I kind of set up the patients side by side and pointed out the difference. In my heart and in my intuition, I don't believe until I pointed that out that there was an awareness, an acute and astute awareness of that big difference. And once I did point it out, and actually I had to point it out on 2 levels that it was happening, because, and I did it not by saying, don't do this, because I didn't have the authority to do that. Basically, I asked a question: why is it that this patient who is this way and this patient who if you read how they presented, it looks like a mirror image, but the medications were far afield. 2 milligrams of risperidone over here for the non-Black patient, and then the other patient, massive doses of everything. And only after I saw that there was a pattern did I ask the question, why and the original answer that I got was because these are the sickest patients. And then that's when I brought in the comparison. Well, this is as sick. If you just take away the face and just read the presenting problem, it looks like the exact same thing. So why? And so can we try to work to do things differently? And, you know, I was able to see that that change did happen. And so maybe some people are using it interchangeably to mean racist, but I earnestly feel that in the instance that I described on the other evening, it was an unconscious bias that once it was brought to the conscious, the behavior, and I'm going to call it a behavior, changed.
And I'm going to attempt to kind of split the line on that because I actually agree with all of the elements of both. And I think, and the definition of implicit bias, what it's describing, I think is accurate. But it is interesting that there's a crucial word that's left out of that, and it's implicit racial bias. And I think some of the reasons, you know, if we look at some of the social determinants of health and social determinants of how we describe things, it is heavily weighted by factors that seem to minimize the kind of negative impressions. And so in some ways, I think the fact that we don't say implicit racial bias is also reflective of the bias, because we leave the key word out, right? Implicit bias is very neutral, passive, automatic, not under my control. And if we assume all of those are true, and those things may well be true, but when we usually describe biases or other things, we're specific to what it relates to. And so I do find it interesting, and I think the similar factors that underlie implicit bias underlie how we've chosen to describe this particular bias, and we've left the key word and the key focus of race out of it. And I think that's reflective of how our society addresses the racial disparities, in that they kind of soften, minimize, and kind of neutralize some of the harsh realities, because the people that are affected by this, no matter what you call it, are directly impacted in very significant ways, and it's universal. And so I do think the fact that we leave the race piece of it out is reflective of implicit racial bias.
Right, I agree with that. And just to respond to your example, Dr. Shannon, you knew this gentleman, and so you knew his tendency, his personality. What I'm saying is that people are jumping to use terms implicit and unconscious without having other information that perhaps it is not explicit, that it is not conscious. We're seeing acts and we're automatically terming them implicit bias or racial bias or unconscious bias. And I think that does not do due diligence to the issues.
I agree with that.
Great, so look at that. We're already starting off here with going through and making sure we all come to terms in terms of even the language that we may be utilizing in regards to this topic. So now to kind of throw another piece of language into the mix, okay. I want to bring up here for us some information about microaggressions. So let's kind of delve into that a bit more. So as you see here on your screen, microaggression, it's a brief and commonplace daily verbal or nonverbal behavioral and environmental indignities, whether intentional or unintentional, that communicate hostile, derogatory, or negative racial, ethnic, gender, sexual orientation, and religious slights or insults. These can occur whenever people are perceived as other, and some groups have a lifetime burden of microaggressions that can contribute to physical or psychological illness. Now, some examples from patients include, you speak English really well, you're so articulate, you really know your stuff, or even things such as walking up to individuals and asking, are you a nurse? So microaggressions, especially from providers to their patients, can include berating a patient for non-compliance, not adhering to their medication, missing appointments, without really acknowledging some of the outside factors that may be influencing those behaviors, such as financial reasons, lack of transport, or childcare, or job restrictions.
Sure.
So I would like to ask you all as the panelists, if you all can add either some other examples of microaggression from healthcare providers, in particular to Black patients, or any times where you've kind of witnessed some of these microaggressions happening in your practice. We can start off with you, Dr. Williamson.
And so what I would like to highlight is the research has shown that the social determinants of health are common to all of us. We as healthcare providers are a part of society. And so those biases we bring into the room with us when we treat our patients. And studies have shown, if you look at the amount of time that African-American individuals have to wait for their appointments, have to wait in the lobby, things such as subtle as special requests, can I come in off-time visiting? Those requests are granted much more frequently with white populations than African-American populations. And so we know with implicit bias, the dichotomy here is Black or brown is considered worse or negative than white. And so some of those biases factor into how physicians respond to their patients. And so some examples include being very demonstrative or paternalistic in their attitudes, engaging the input and preference of Black and brown people in their treatment decisions, automatic association with issues of noncompliance or other difficulties with treatment as characterological or typical, and then also making assumptions that reduce their willingness to expand options for treatment because they assume they can't afford, won't comply, won't understand. And so it starts to limit their care choices. And these are all things that the patient wouldn't even identify. They can feel it, but they don't really know what it is. And then that affects their compliance, right? It affects the treatment alliance. There are also studies that show that Black and brown people get less empathy in their treatment interactions because when they're seen as other, that automatic understanding and compassion that comes along with that identifying with the patient is impacted. And so all these factors build into a treatment experience where we get less positive outcomes for people of color. And then when we evaluate those outcomes, most of the studies look at these individuals and then decide that the factors for lack of a good outcome are attributable to the characteristics of that individual and don't take into account all the things on the provider side. And estimates have shown upwards, I mean, it's just even looking at financing costs, we're talking $310 billion a year. You know, I mean, not that that's the most important thing, but that's the magnitude of this. And so those are factors that contribute to, on a broad scale, nationally, more negative outcomes. And again, when we go to research that, we're looking for factors in those people to find the reasons why the treatment isn't going well. And that is only half of the story at best.
Dr. Shannon, anything in regards to microaggressions from your side? Anything that you feel like other examples that you have of microaggressions or any thoughts in terms of microaggressions?
Just to echo Dr. Berkeley's comment about the nurse thing, I've spent the greater part of 40 minutes of an initial evaluation getting information from a patient only to have them say, hold up, wait a minute, all this is cute, fine, and good, but when am I going to see the doctor? Only for me to have to tell them, you've been seeing her for the past 40 minutes, and have them actually look to see where she is. Right here, oh, okay. Well, you don't look like a doctor. Well, what does that look like for you? And I do, I want to know, because I'm a researcher at heart. What exactly does that look like in your world? Yeah, so that's an example.
Dr. Berkeley, anything that you would like to add?
Well, I think that the example that I gave earlier of, someone interacting with a front desk staff, and that can happen in the medical facility as well. I think that's an example of a microaggression where someone presents and they, in their mind, they are more important. What they have to discuss is more important. Their time is more important, and they just intrude upon without perhaps even seeing you consciously, without consciously realizing that you're even there. Sometimes they just intrude upon that interaction and demand that time. I think that probably something else that we've seen within medicine is, and within psychiatry, that's been interesting, is when we think about substance abuse has been within psychiatry for many years, and we have always recognized it as a condition, as a medical condition. It's interesting that it was not until it was recognized that opiates were being used to a large extent in a suburban or a majority population that we really publicly started to acknowledge substance use as a medical condition, and not only acknowledge it as such, but also make sure that legal repercussions of that reflect the fact that it is a medical condition, as opposed to someone behaving badly or just being a drug addict.
And on the comment of Dr. Berkeley regarding the opiates, I can take it to another level. Once it was established that it was a problem that was, seeping into the majority community, at least here in Atlanta, there was the edict that we call them, in colloquialism, bus or ambulance would be equipped with
Right.
Narcan.
Right. Yeah.
And I have the misfortune, but it's actually a fortune because I will use it as a platform to know of instances for people that I know where, because they are South, there's no Narcan. But I would love for somebody to do a study to know how many ambulances that are delegated for the North have that issue. And
Right.
if I were a betting woman, I would bet on the outcome of that study. But it really does need to be done, because if it's been said that because of the epidemic of the opiate crisis, that's going to be the state, then why do I have a couple of instances where it happened so frequently that when I'm getting a call that somebody is in respiratory distress, why they call me before 911 is a whole nother subject that I have to instruct them to tell the dispatch operator, because you live on the wrong side of town, to make sure that ambulance has Narcan on it.
Yes, and I would add, just to support those sentiments, I mean, I think once the substance use, our awareness of it became much more impactful to the majority population, it transitioned from a criminal behavior to a mental health problem. And for it to even be defined that way, but it's the exact same condition, and that's an example of how things in society the perception of them are changed depending on who it is affecting. And I'm also, the other piece to this is, I think we're talking patient-provider interactions. It even seeps into the upper levels of management and coordination. Recently, someone reached out to me once the George Floyd incident occurred, unfortunately, and they were asking, they wanted to make a more public comment to their staff, and they called me and asked me if I knew anyone who was expert in these kind of issues so I could refer them to that person. So knowing that I've published in these issues, I'm an African-American male practicing for 20 years, they didn't see me as a person who would be an expert, which I found pretty interesting.
Pretty interesting to say.
Yes. Now, to further this conversation in terms of microaggressions, so the action method, which was published in 2016, suggests that microaggressions can be addressed in 6 steps. So A, asking clarifying questions. C, carefully listening. T, telling others that what you observed was problematic. I, impact consideration for yourself or potential others. O, own your response. And N, next steps. Now, Dr. Shannon, I definitely know that you've spoken a lot about how you actually will ask clarifying questions and address some things, but any other specific tactics that you believe can work in regards to addressing microaggressions?
Giving in-service lectures about it, including more in the curriculum. And we talked about it before, really a lot of times the people who are interested in these things are not the ones who are, how can I say, abusing or
Perpetrating the acts.
Yeah, perpetrating the acts. It's like preaching to the choir, but it's the other folk, the audience members who really could benefit from knowing about these things. It's kind of like one of my mentors, Frances Cress Welsing. Anybody who would show up for her lectures really already knows what, you know, the topic is going to be, where it's going, and they just really love to hear her speak on the topic. But but the message needs to reach a broader audience than the person who might tend to read the ISIS papers, which really talks in depth about all of the microaggressions, and in places where we aren't even readily aware where they're occurring, like even in sports, and who plays what sport, and what the ball looks like, and where what phallic symbols are found everywhere. So you know, just speaking out about it, but not in a hostile, angry kind of way, even though sometimes just because of the color of your skin, if you say something that somebody's not used to saying, it's perceived as angry when you're really just trying to educate. And don't be afraid to call it out for what it is. And you can do so in a kinder, gentler way, and still, like I explained in my example, where I was able to, you know, affect a change just by asking the same question on two levels.
Dr. Berkeley or Dr. Williamson, any other specific tactics that you all would suggest in regards to addressing microaggressions?
I appreciate the action technique. It seems that it would require a willing participant to go through those action steps. Something that maybe is just a little bit quicker, because sometimes people are doing these things and they're not aware, at least in the moment. I would just quickly, you know, point it out to them by saying, excuse me, do you mind if I finish here first? Things like that. And that tends to bring it to their consciousness. Now, if they were intending to be not nice, then they may just continue with whatever they were doing. But that is a quick way to sort of bring people's realization. They might be rushing, they might, you know, and they just may not be aware. And I think that tends to work pretty well.
And I would add that, there are factors on the individual level that I think are pretty well described in the current conversation. That requires intent, right, on the individual level, but I do tend to think of these things in larger scales. And in my opinion, I think we approach it like we would any major public health issue that would relate to a different population. We put money into research and we study it. And then we take that information and we make changes in how we train individuals who provide care, who receive care, and factor those things into other determinants like patient outcomes, reimbursement, and measures of efficacy of treatment. And so again, I always believe you can tell a lot about an organization, a society, an institution by where they put their time and money. And so to that end, an example that I've seen in some organizations here locally is that they include training for their employees prior to them ever setting foot in a room where they can interact with a patient about implicit bias. And that can, those things communicate the importance of it and bring it to the forefront. It shares information, allows someone who's willing to have that intent to utilize that, learn more, and then expand upon that. And so, again, it's like any other public health, mental health issue. We put the money and the dollars into research and take what we learn. And then, again, the word is action, right? We take action, but on a broader, larger scale.
Great. Yes. Thank you all so much for sharing those specific kind of tactics to help some of the individuals, perhaps in the audience, have some different things they can utilize out of their tool belt to address some of these things. Now, once again, audience, please remember that you can utilize your chat function to send some questions that you may have for our panelists. But we did have some really good questions from our Monday's audience that we thought were great and wanted to add to this conversation. And one of them was asking, can bias be interpreted or recognized as transference in the therapeutic relationship with mental health patients? So Dr. Berkeley, what are your thoughts about that?
Can bias be interpreted as transference? That's interesting. I've never thought of that before. And I don't do much therapy. I am more medication management. I guess the example would be if a Caucasian psychiatrist sees an African-American patient and they're thinking that the transference is occurring. I'm not clear on how that might happen. Do you have any clarification on that?
No, it was just simply asking just if it can be interpreted or recognized as transference in regards to that relationship that you all as providers may be having with your mental health patients.
In my opinion, I do believe that any bias affects transference. The ways in which we relate to our patients are kind of automatic systemic beliefs, right? Especially the ones that we haven't self-examined come to play in our understanding of that individual. And so I think unconscious or implicit bias is as much of a influence on transference in the therapeutic relationship as anything else. And again, it's one of these things where if you don't have the intent or the understanding, now you have factors influencing your understanding of the patient or the client in ways that you can't take action on because you haven't brought that to light. And then that leads to misunderstanding. It alters your interaction, and then you get less positive treatment outcomes. And in addition to that, those are the types of things that the individual who is impacted by the unconscious bias, they're well aware of it. They can sense it, they can feel it, they experience this probably daily throughout their entire lives. And so you can imagine going into a relationship where someone is supposed to help and be therapeutic, and you have to be willing to be vulnerable, and then you experience these biases, that certainly pulls at the threads of the therapeutic alliance. And again, I think that factors into lack of follow-up. We'll call them non-compliant, right? And again, those terms blame the individual who is subject to the unconscious bias, and then they move on to the next patient where it's likely to happen again.
Great. Now, another question that we had was really also thinking about gaps in clinical education and how those may be contributing to clinician bias as well. So what do you all feel can be done in order to change this?
I think I spoke on that one just a little bit, and actually offered as a remedy that majority clinicians consider attending conferences that are put on by minorities, because my ability to ask the question of the clinician where they were given a black patients, plural, mega doses of antipsychotics, had they come to any one of the transcultural conferences that are offered by the Black Psychiatrists of America, they would have data, you know, just coming, flowing left and right that speaks against or explains why, even though you think that you're doing something that is appropriate based on size and race, the research actually speaks against that in people of color. And I'm not just talking about Black people, but I'm saying in people of color, period, because they aren't participating in the studies, you know, in droves. You know, they remember the Tuskegee experiment, and they're not going to be a part of that. And they would come to a conference and be inundated with this kind of material by experts who are of color, who have studied these things in depth, and then they would be more knowledgeable. And I can tell you that, you know, I've attended conferences for both sides where the in-depth knowledge or information regarding how you prescribe in people of color and things that you have to consider that aren't normally considered, I've only heard that to the depth that allowed me to ask those questions at conferences where they were put on by minorities.
And I think it's interesting because I noticed, I think a lot of schools now are talking about cultural competency, again, another euphemism, and encouraging that students become more informed about cultural competency. And I haven't flushed out this idea entirely, but my thought is when we in medical school or residency, we are learning about a specific topic or whatever, we do a didactic experience, but we also have a clinical rotation, some sort of practical experience. So I feel like in order to address biases, I love the idea. I agree entirely with Dr. Shannon that, you know, we definitely can get a lot of information from attending those conferences and those talks, but I feel like there also should somehow be a practical experience to it. I'm not sure how that would really manifest in a teaching institution, but really it's got to be part of your life that you're not practicing these biases, in order for them to be actually genuine and not play a part in your treatment.
It's interesting listening to Dr. Berkeley. I just had a flashback of medical school that kind of speaks to this. And I'm in a pathology class where we're in small groups and we're presenting, and I'm in the minority, so I'm the only one in the group that happens to be an African American. And the first person to present in our small group stands up and says, we have a 57-year-old colored boy. And I say, and you start over. So the young man stands up taller and he speaks louder. He starts over. He says, we have a 57-year-old colored boy. And I say, you have to start over. And then when he goes to say it again, I say, just stop. Maybe I should ask you, in your culture, when does a boy become a man? Because in my culture, if you're over 18, you are a man and not a boy. Number two, the word colored is offensive to Black people in America. Now, in some other place, maybe it's cool, maybe it's okay. Now, I was asked a legitimate question, which was, well, what about the NAACP? Well, that was named back then, and it's kind of like the N word. Some people can say it and some people can't. Whether they should or not is not equal across the board. And then he backed it up and he, said we have a 57-year-old African-American male. So that was the first week. The next week, a young lady stands up and says we have a 35-year-old negress. I almost fainted because I said, this has to be, I'm being punked or something. Where's Ashton Kutcher? Because this girl could not have said this. And I said, what even is that? I mean, I had never even heard the word before. And so
I'm familiar with it.
I wasn't familiar. And so, because, she was there the week before when I had, restructured things, and I'm no teacher, so I was in the class just like everybody else. So then, first of all, the first young man, he apologized afterwards and said he was very sorry, but he was raised in South Georgia, and that's how he was raised, and he didn't know any better. And thank you for letting me know. The young lady took a different approach. She said, look at this. This is how this autopsy is written. And this was in the 80s now, but the autopsy came from the late 50s. So I wouldn't be having my ears burning off the side of my head. I went through every case for my whole entire class and found a number of these kind of misprints. And when I presented it to the president of the institution and the chair of the department, and not just offered it as a criticism, offered to even put time equity into correcting these things and helping them to know what was proper and what was not, I was surprised they actually went and changed 200 autopsies to get rid of the offensive language. So I applaud them for that. But I was equally astonished that I was not the first African American to have heard this, but obviously no one had said anything about it. So it takes the willingness, like somebody said earlier, on both ends. Somebody willing to teach and somebody willing to learn for you to have this cultural competence, and also work with the realization that I'm a glass half full girl, but you're gonna always have some outliers that aren't interested in doing it differently.
Yes.
And
Oh, no, I was gonna say, just being mindful of our time. We do have a question from an audience member. So, Dr. Berkeley, I know earlier you talked about kind of the usage of the term unconscious bias, but we just wanted to see if non-compliant versus non-adherent could be kind of considered utilizing those terms as a form of unconscious bias. What are your thoughts in regards to that?
Well, I think that the term non-compliant, which we are now trending towards the term non-adherent, I think that it is less a form of unconscious bias. more comes out of the history of medicine, where we tended to be a bit more paternalistic. And so we give an instruction and we expect the instruction to be followed. But now we see medicine more as a collaboration. And so I think that is where the term is, it's transitioning more to non-adherent versus non-compliant. So that's what I think is behind the change of term.
Great, thank you for that. Now, one thing we definitely wanted to make sure we address is really just thinking about some actual specific things that you all, that clinicians can do overall. I know that you all are, you know, individuals that are Black, but individuals that may not be Black, some things that they may be able to do to kind of demonstrate to patients that are coming into their office that it is an inclusive environment and that they are welcome there. What are some specific things that you all feel those individuals can do?
Well, if I can jump in, I think that there are a number of things that can be done. I think one is making connections with people of color who are within your profession, having clinical conversations, talking about outcomes with patients. What are some of the things that they could learn about these patients that they wouldn't know otherwise? Oftentimes, exposure to a culture that is other than your culture can lead to their own experience, if they have the intent of learning a better understanding of what the circumstances are in their experiences, and then those things can be factored in. I think that's one of the ways in which an individual can kind of start to learn what those experiences are like and what they need to know and be sensitive about. And I think, again, the other piece to that is one of the ways you can get to that is if you're a person in a position of power, is employing and engaging and interacting with people of color within the profession at all levels. And I think that breeds diversity, which gives the opportunity for those kind of things to happen a bit more naturally in creating an environment that is more inclusive, literally, but also in the collaborations within healthcare and the provision of care to patients.
I think you're on mute, Dr. Shannon.
Go on.
Okay. Go ahead.
Kind of piggybacking off of Dr. Williamson, also as a clinician, and this is more general than just race, but speaking more to culture, because there are cultural differences within the same culture,
right.
And being transparent and not being afraid to say, now, what does that mean? I don't understand that terminology, so help me. And I know help me is like old school terminology, but help me understand what you just said meant, what that word meant. In thinking about maybe even, you know, talking to, because I treat every age from 3 to 103. And sometimes the lingo of the younger generation, I am not ashamed to say, okay, before I knew what on fleek was, I thought that was like on some street or something. You know, I want to be there, but what is it? You know, just being transparent and asking and just letting a patient know that you're interested in knowing what they're talking about. It engages them and makes them feel less vulnerable, or kind of diminishes their sense that maybe you might not be interested in their issue because you're from a different culture, age group, whatever.
And I would definitely agree with all of those strategies. And I would say probably the most important thing, what I would hate for our patients to encounter is someone who is feeling safe in an unsafe environment. So what I would really encourage is that the safety is genuine. So again, as we talk about the underlying cause of some of the things, the discrepancies that we see, and we think about racial biases, if providers can sort of confront their racial biases and address them, then they can genuinely provide, you know, safe and equal care. So I think that would be important. And just treating everyone with respect and dignity goes a long way. Everyone, regardless of their race, I think that, you know, really tends to be helpful. Within psychiatry, and actually within any medical practice, I think also using proven effective treatments is going to be essential. So making sure that you are following the same guidelines for everyone. What is useful now is that a lot of us are using electronic medical record systems, and we can run reports on various things. So within psychiatry, what we know are some of the pitfalls, the big pitfalls that we see in terms of treating African-American patients. We see that diagnosis tends to be different. We tend to be diagnosed as psychotic more often than others. We tend to receive typical antipsychotics more often, or higher doses. We can now, because through our EMRs, we can run reports on these things. So you can double check on yourself as to whether or not you may be doing some of these things, perhaps not really recognizing it, and then challenge yourself and address those things. So I think those are maybe some additional strategies.
Yes. Thank you all so much for that. We are out of time, but thank you to our audience for being here tonight. Hopefully you all gained some information from our wonderful panelists. Thank you to Dr. Berkeley, Dr. Williamson, and Dr. Shannon for joining us tonight and sharing your knowledge and your wisdom, and hope that you all walk away from this with some new understandings and learnings. When you leave the meeting, please check your email for a survey about tonight's panel. We really would appreciate your feedback so that we can make sure that we can continue to have events like this and make them even more successful. So thank you all. I hope you enjoyed the rest of your night.
Thank you for having me.
Bye.